I'd like to welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olewski, the host for the Vasculitis Foundation Educational Webinar Series. I'm also a patient living with MPA vasculitis, and today's presentation is about the SAFE-T study. These webinars are part of the Vasculitis Foundation's commitment to patient education, and so we'd like to thank our sponsors, AstraZeneca, Amgen, and Novartis, for supporting these webinars. We're very grateful today to have Dr. David Massicat-Arzanouch with us to educate us about this study. And Dr. David is a nephrologist and assistant professor at the University of Ottawa and associate scientist at Ottawa Hospital Research Institute in Ontario, Canada. He's been awarded a 2-year grant through the Vasculitis Foundation's Young Investigator Awards program. And the aim of his study is steroid minimization in ANCA-associated vasculitis for safe, effective treatment, or otherwise known as the SAFE-T project. And it's to develop a clinical trial that will look at minimal use of steroids, no more than 4 weeks, during induction therapy of severe anti-neutrophil cytoplasmic antibody-associated vasculitis, with the use of current standard of care, widely available immune suppressants. So welcome, Dr. David. We appreciate you being here today, and I need to ask if you have any disclosures before we get started.
Thank you very much, Kathy. I'm very happy to be here. I have no disclosures relevant for this talk.
Okay, great. Well, then, if you would like to share your screen and start educating us about your study, I'm very excited to hear about it.
Okay, I will share this. All right, so I'll go in presenter view. Okay, are you able to see that?
Perfect, yes.
Okay, perfect. So I'll just get started, and at any point you can just kind of interrupt or ask questions if something pops up. So this is, hi everyone, my name's David and I'm a nephrologist, as Kathy said, in Ottawa, Canada. And I'm looking at a project to basically decrease immunosuppression or the burden of immunosuppression, and particularly focusing on glucocorticoids, which I'll refer to as steroids going forward, in ANCA-associated vasculitis. So just a bit of background about what brought me to get to this project is that we know that ANCA vasculitis is a rare systemic autoimmune disease. It can be organ and life-threatening without therapy, but sometimes even with therapy. And the treatment is often quite heavy immune suppression that's given up front, and that's usually steroids combined with another agent that's typically been cyclophosphamide or rituximab. And what we've seen is that with these treatments, the majority of patients actually do fairly well in with regards to control of their disease. So their disease gets under fairly good control, and they're able to attain remission of their disease. Studies show about 80 to 90% of patients, and that's what we tend to see in clinical practice also. But one of the major issues is the side effects to medications, and that's a major cause of, I guess, harms and problems for patients that will affect their quality of life, that will lead to medical complications, and even death. And obviously, the treatments are immune suppressants, so we're lowering the immune system. So infections are a huge concern. And actually, infections in patients with ANCA vasculitis is a leading cause of death in the first year after diagnosis. So there's been a lot of focus on trying to decrease toxicity from treatment while maintaining good control. And that's kind of what this project works on and tries to push even further, and in particular focus on some of the glucocorticoid steroid side effects. So the main objectives of this project are to improve the safety of treatment of ANCA vasculitis. So that's decreasing infections, because that's a major burden for patients and a major cause of death in patients with ANCA vasculitis. How to do that? By minimizing steroid use. That'll also decrease the steroid-related side effects, but all the while we want to do this while, of course, maintaining the good control, good effective control of the disease. So getting patients into remission, relieving their symptoms, having improvement in quality of life from resolution of their vasculitis symptoms. And also it's a way of perhaps providing alternative options for steroid-sparing treatments. There are newer treatments that are available now that can, in many patients, drastically reduce the amount of steroids, but those treatments aren't available for all patients, and it'll depend on, insurance coverage, the countries where the patient is. So it's just providing another way of offering patients reduced and really minimal steroid use with our widely available therapies. So I guess the kind of the steps involved in this project. The first part, while these are kind of ongoing in the same time frame, the first part is to do a sort of systematic review, and that's basically where we get all the trials, all the studies that have looked at lower steroid use for the treatment of any type of autoimmune disease. And we look at the results of those studies and we kind of try to put it all together as best we can into one kind of big study where we call this a systematic review, where we review what all these studies say in terms of the side effects related to steroids, and to really try and, as best we can, quantify the potential benefit of reducing the steroid exposure and steroid doses for treating autoimmune diseases. The second part is to conduct a randomized clinical trial to study a regimen of low minimal steroid doses for the treatment of severe ANCA vasculitis. And there have been steps that involved along this. And this has been supported by the Vasculitis Foundation with the award that I received, and I'm very grateful to the Vasculitis Foundation. So when we're trying to conduct a trial in a rare disease like ANCA vasculitis, it's important to make sure that we have the right design, that clinicians, researchers are going to be willing to participate, and that patients are going to find this a relevant question and something that's worthwhile doing. And so some of the background work behind developing this study was surveying clinicians to get an idea of what the best design would be to examine this, what the best treatments and comparator treatments, what the best dosing of steroids. Also, it was important to get the opinion of patients, so a patient partner focus group where we went over the relevance and the importance of the question and the means we're going by to achieve this. There's a lot of work that goes into the development of a protocol, getting the appropriate approvals, getting the protocol published, and that's all kind of background work that has to lead up to actually starting the study and patient recruitment, which is the final step that I'm hoping to get started in the next 2 to 3 months now, with everything that's been done on the background. So if we think of potential benefits for the systematic review, that's going to look at, the different the different side effects and, reduction in risk that's possible with lower steroid doses for autoimmune disease, I think it could give us a much better understanding of the risks associated with higher steroid use for all types of patients. And, one of the benefits of this is that it could extend to, research in all forms of autoimmune diseases, rheumatoid arthritis, large vessel vasculitis, other forms of autoimmune kidney diseases that are not vasculitis, lupus, for example, and potentially encourage researchers to find other treatment regimens that will reduce steroid exposure to improve patient outcomes and quality of life. And then, of course, the big part is the clinical trial that I'm developing of a low-dose steroid regimen for the treatment of severe ANCA vasculitis. Obviously, my major objective is to improve patient outcomes in the treatment of their disease. And that's with less infections, better quality of life from less side effects from the treatments, giving patients access to what I call a widely available means of reducing steroid exposure, all the while maintaining good control of their disease, which I think is possible with the trial that I'm developing. And so this project has been supported by the Vasculitis Foundation Award I received, and I've also received some support more locally in Canada, in my hospital organization and in my province, to help support the project and the trial development and undertaking the trial. And wherever I use I in this, I have to say that I'm working in close collaboration with Dr. Michael Walsh, who's a great trialist and who undertook the PEXIVAS trial that informed on a lot of the same questions. And so a lot of thanks goes out to him for his guidance that he's provided throughout this undertaking.
Well,
And,
great.
Yeah, that's what I had so far, Kathy.
I was just going to say that was a great overview. And if you want to stop sharing your screen now, we can talk a little bit more about some questions that have come up from patients over time. We frequently do get patients about steroids and steroid use. And if it's okay, I'm just going to ask you some of the ones that have been sent in from our patients in our community.
Yeah, absolutely.
Okay, so the first one is, I'm newly diagnosed with EGPA. My doctor keeps talking about induction therapy, but I'm not clear on what this terminology means. My understanding is induction therapy is the initial treatment given to a patient. When a doctor first diagnoses a patient, how does he or she determine the dosage of steroids needed to be most effective? It's a really good question because we like to have information available for our new patients as these things start to come up for them.
Yeah, and no, it is a very good question. We often use like very specific terms like remission, induction, maintenance, and things like that. Induction therapy basically is, the way I see it is, and the easiest way to explain it, it's the initial part of treatment that's going to be more intense because we're starting treatment for usually when the disease symptoms are at their highest. And so what we're trying to do with induction therapy is to get the patient into a remission. So a state where they no longer have manifestations of active disease, of active vasculitis. So basically, we're trying to get their vasculitis quiet. And to do that, we have to use high doses of immune suppressants. And since, the symptoms are more severe early on, patients, have often been living with them for months, sometimes even a year or more, before they get the proper diagnosis. We tend to give higher doses and a combination of medications of immune suppressants and anti-inflammatories, and this is where steroids will often be used at higher doses. So that's basically what induction therapy, what it means when a doctor says, I'm giving you induction therapy, it's I'm trying to get your disease quiet. It's active, it's like a fire's raging. Let's put that fire out, let's put it out, bring it down with our medications, with our anti-inflammatories, and see how we can do that, how we can achieve that with the amount of medications that we need.
Okay, thank you.
Well,
Go ahead.
Just to go to the second part. So how do we determine what amount of medications we're going to use? I'd say it's it'll very much vary depending on the physician, their practice patterns, their habits, the patient, how they present. the types of organs that are involved. But in general, we're guided by studies that have been done that will guide, how much steroids we can use. I think people know a lot about the PEXIVAS study that kind of found that we can use a lot less than what we previously were using. And so a lot of times, we'll use that as kind of our go-to steroid regimen, but a lot of times it'll be adjusted based on the patient or, prior experience. If we have someone that we're even more worried about steroid side effects, maybe we'll use a little bit less or we'll adjust that. And it's something that requires ongoing assessment, which is why we often follow patients very, very frequently in the early phases of induction treatment, because we need to monitor for side effects, for response to treatment. So that's kind of how it usually goes.
Well, that all makes a lot of sense. Okay, and moving on to question number 2. This patient says, my understanding is that the current strategy is to put a newly diagnosed patient on the highest amount of steroids as the first treatment to control inflammation and reduce damage, which you just went over, of course. But their question is one of the goals where newly diagnosed patients could start on a much lower dose of steroids, but still achieve control over the inflammation?
Okay, that's a excellent question. What the patient is saying and their understanding is that that is correct. Overall, when someone is newly diagnosed, we're using higher doses initially. I guess my objective, when you look at dose, so the way I look at it is more the duration of steroids. The doses that would be started upfront early on, like in the first days and the first week or two, might be similar to what's already being done. The difference is how long we're going to be continuing the steroids. Typically right now, they're started on 1 milligram per kilogram approximate right up front, and then it's kind of reduced after a week, then after 2 weeks, gradually reduced, and then over the subsequent 3-4 months, it's reduced down to the smallest dose. What what I'm trying to examine with the project and the study is using much less time the steroids. So less, once you reach 4 weeks, after 4 weeks, no more steroids would be required. And we'd be able to achieve proper control of the disease with the treatment up front in the early phases. So kind of more intense, not more intense, but more immune suppression up front. But once we achieve the control of the disease, we don't need to continue that, and we can stop the steroids faster because we're using the other agents that will help maintain the control of the disease that's been achieved with the steroids. So I guess it is, it's a lower dose, but not, the initial dose might be similar to what's being used right now, but it's going to be used for much less longer. So in the end, what I like to call it is a lower exposure to steroids. And personally, I've found, and patients often find, that the steroid side effects, they really come on when you're on it for a long time. So it's the weeks of use of steroids that really kind of, patients start feeling the side effects, the weight gain, the, body changes, that we start seeing the diabetes, the high blood pressure, that we can see, vision problems, muscle weakness, stuff like that, and infections, obviously. So the goal is to, I guess, try to use it appropriately very early on, but don't use it for too long so that patients don't have side effects.
Well, that's a really interesting clarification, and I'm glad you explained that, because I'm not sure we all would have gotten that we might need that full dose, but for a shorter period of time. That's very interesting. I hope that the study does prove that, actually, as someone who was on a lot of steroids in my induction phase for a long time.
Yeah,
Um,
absolutely.
okay, and let's move on to the next question. It says, I know steroid reduction is a major goal for patients. Do you, as the doctor, imagine a day when steroids will be eliminated and replaced with another type of therapy medication that will be just as effective as steroids, but without the side effects we get from the steroids?
Um, I guess that my response to that would kind of tie in a little bit to what I was saying before. I think, it's kind of become one of the major goals of research in vasculitis is trying to find that, can we get away with how little steroids can we get away with to treat the disease properly? I personally am not sure if we'll ever get to the point where we use no steroids, as in zero, none at all. I think, in particular, I mean, I'm a kidney doctor, so I see patients that tend to have very organ-threatening disease, and what we would qualify as most severe types of vasculitis, some of the more severe types of vasculitis. So obviously, patients that have lung bleeding in their lungs, and obviously that's extremely severe. But from if I'm focusing on the kidney aspect, I see patients that are going into kidney failure that need dialysis, and we're trying to save their kidneys. I don't know for those patients that will ever get away with using absolutely no steroids. A lot of times steroids are given IV initially for, 1 or a couple of days, and then we give them high doses. And the way I see it is that, vasculitis, I see it as like a fire raging in the blood vessels in the kidneys. And we got to get that down. We have to bring the inflammation down as quickly as possible, in order to save the kidneys, to make the patient feel better, to get their disease under control. And, I don't know that we've discovered a more effective anti-inflammatory than steroids. And, nature's given us cortisol, and, we all have our own steroids in our body that our body produces, and to help us deal with, stress situations. And I think there's a reason that nature kind of evolved to give us that. And I'm not sure we'll ever find a better anti-inflammatory, but I think we can find a better way of using those steroids. And so it's to try and, I guess, if I can say, harness the effectiveness of steroids, because I won't lie, patients often feel a lot better initially in the first days or week or two that we give them the steroids, because they finally get their symptoms resolved, their fatigue gets better, their joint pains are better, they don't have eye pain, they can breathe better. It's quite remarkable, and almost, it's quite satisfying as a doctor to see that, and we see their kidney function get better a lot of times. And so I think the way I see it is we don't necessarily need to get completely away from steroids. We just need to get to a way of using them with as little as possible, such that we're able to get that initial effectiveness in relieving patients' symptoms and improving their condition without getting the side effects that come once we're on it for weeks. There have been treatments that have been developed to kind of get off steroids within a month. And those treatments have been shown to work. I think that there's ongoing study to try and find other ways of, reducing that even more. I don't know, though, personally, that we'll ever get to the point of absolutely none, but, who knows, 50, 60 years from now, when I'm not even practicing medicine anymore, maybe we'll have found something, but I don't know in the next, 10, 20 years if we'll ever 100% eliminate it. But in my experience, if you're giving steroids for only a couple weeks, a lot of times the side effects are not that bad, certainly a lot less than what patients are currently experiencing. And already, if we can do that, I think it's a fantastic compromise between reducing side effects and still getting good control of the disease.
I think that's super well said, and I appreciate your perspective on that, because we all would love to have the benefits of what steroids can give us without the complications of what steroids can give us. So
Yeah.
the fact that you're moving in this direction is just amazing. I just
Yeah.
want to go
Oh,
ahead.
sorry. Well, I just kind of wanted to add that, that's kind of what the recent studies have been, in the last 4 years, there's been a couple studies that have looked at, using less steroids, and we're trying to kind of see just how low we can go. I don't know, if we keep seeing that it's working, and maybe that just keeps, we keep pushing it to reducing more and more and more, maybe we get to that point, but I'm just not sure we'll ever 100% eliminate them.
Well, we're happy for the compromise right now. So we appreciate this study. And speaking of this, the safety study, one of our patients would like to know, is it related to the PEXIVAS trial, which I think you already said it was right in the very beginning. But the question is, or is it a study that expands on the results from the PEXIVAS study? So maybe just go into the differences for us, the purpose of this one.
Yeah, so the PEXIVAS was the largest trial ever conducted in ANCA vasculitis, and it actually looked at two questions. So it looked at reduced steroid for treatment of ANCA vasculitis, but also the use of plasmapheresis for ANCA vasculitis. So my study doesn't address plasmapheresis. It's really looking at the steroid dosing and the regimen, the treatment combination to use less steroids. The patient population is somewhat similar to PEXIVAS. So PEXIVAS were patients with what we deemed severe ANCA vasculitis that had severe kidney involvement or severe lung involvement. And so the patient population will be similar in my study. It'll be patients with severe kidney involvement from their vasculitis. And what we're looking at is, I guess, going even lower than PEXIVAS in terms of the steroids that are being used. So PEXIVAS, at the time it was developed around, the time it was conceived and designed was around 2010, 2012 or so. As you said earlier, Kathy, a lot of steroids were being used at that time, a lot of steroids. And so they developed a design with, about halving of what the standard at that time was. And so what we're looking at now is using even less than PEXIVAS, again, in patients with very severe disease that normally, we would be treating with the, let's say, PEXIVAS type of steroids. We're trying to use even less than that. So it's not I guess it's an extension in the sense of we're going on the same theme of reducing steroids, of finding ways of reducing steroids in vasculitis, but it's another study, it's a study of its own. So it's not using the same patients. It's really like a full new protocol, new funding, new investigators. But as I said, I am undertaking this with Mike Walsh, who was the main investigator for PEXIVAS. So there's a lot of and a lot of the potential collaborators in this study, as it kind of grows, we're also involved in PEXIVAS because it's touching on the same themes.
Okay, that's a great explanation. I'm going to throw a question at you that came up because you said you were just entering the phase, or maybe getting close to the phase, about recruiting patients. So I'm curious, how do you recruit patients for a study like this?
Yeah, so again, since these are patients that will have severe kidney involvement, a lot of times it's patients that present to our hospital. They present with kidney failure and you kind of investigate what's going on and you find they have vasculitis, you diagnose them. So it's really on their initial diagnosis of vasculitis. And most of these, just because of the types of patients we have, will be in hospitals. Some of them might be in clinics, that get referred to a nephrologist or a rheumatologist for possible vasculitis, and then you end up working them up and you diagnose them. But most of these patients would probably be recruited from being admitted in hospital. So kind of when they're feeling at their worst, when their disease is most active, and when we kind of need to start treatment right away. Those are the types of patients that would most likely be the ones that would be included in our study.
Well, I assumed that. I just wanted to ask for everybody that's watching this that's interested in it. So thank you for clarifying. And this is kind of more of a background question. Can you tell us what drew you to nephrology as a specialty?
Yeah, no, I get that question often. I guess in medicine, we always kind of divide early on whether we're going to be surgeons or we're going to be more, in the medical aspect, so non-surgical. And I knew I didn't want to be a surgeon. I didn't want working with my hands, and I wanted more kind of focusing on the more, thinking, the thought process of diagnosing and managing with medications and following up patients on the long term. And nephrology kind of, got my attention when I was a medical student, because it's actually one of the specialties that forces you to keep a very good grasp and an overall view of the patient and the functioning of the human body. So I like the idea of being able to specialize in one organ system. So being a specialist, being comfortable with the diseases of that organ, all the while keeping a very good understanding of the body overall, of the physiology, of how other organs work, of diseases of the other organs. And nephrology was very good for that, because the kidneys actually are the organs that are responsible for maintaining equilibrium in your body, making sure your electrolytes, your acid base, your blood pressure, the fluids, everything remains kind of normal and stable, such that we can, live comfortably and normally. And so for the kidneys to do that, and for us as doctors to understand that, you really kind of have to understand all the organs of the body to some extent. And so that's kind of what definitely pleased me about nephrology. And I'd say, once I got into nephrology, or once I, did some rotations in nephrology and got exposed to it, what I really loved was the long-term follow-up you can have with patients. You really get to see patients throughout, sometimes, the worst and the best of kidney disease. You can see them when they have a severe disease. You can treat them. You can sometimes see their kidney function improve. And actually, that's what drew me so much to vasculitis. Vasculitis is a very multi-systemic disease, meaning it can affect many different organs. And so, that pleases my intellectual curiosity of understanding different organs. But also in vasculitis, it is a chronic disease. There's no cure for vasculitis. Patients that have vasculitis get it under control. It's quiet, but you can never say it will never come back in your life. So you get that long-term follow-up with patients. You get to see them throughout their disease, and you get to see how their disease evolves. And you get to often see in vasculitis that their disease gets better. And I think that's something, hugely rewarding, that we can actually, the way I say it, it's so rare that we can give back organ function to patients. But I feel that in vasculitis, we can often do that. And with many other types of kidney diseases, we can do that, and including kidney transplant, which, thankfully, not too many patients with vasculitis need. Unfortunately, some do. But, to be able to, in nephrology, have kidney transplant where you can, in a way, cure kidney failure, but you give them a low immune system and immune suppression, but you can give them back kidney function after having kidney failure is also extremely rewarding. And it's nice to see those patients and to continue to follow those patients afterwards. So nephrology, I think, is, you can have like doctor-patient relationships that last decades in nephrology. And so I kind of like that aspect of medicine, and, vasculitis ties into that also. That's what kind of drew me to vasculitis and what we call glomerular diseases, diseases that affect the filters of the kidneys, because you can have that long-term follow-up and that potential for, improving kidney function. And it's not often we can say that we can do that in medicine, to give back organ function, but so it's something I'm very, very happy to be doing, and I wouldn't want to be doing anything else.
Well, I can tell you as a vasculitis patient with kidney involvement that we're very happy you were drawn to nephrology and that you are on this safety study right now. I feel that you're already working towards improving all of our lives. So we're very happy you were drawn to nephrology and are working on this. And I'd also like to say to those of you that are watching this webinar today that there is a great article on Dr. David Massicat-Arzanouch on the homepage of the Vasculitis Foundation website. I believe it's in the lower corner of it, but anyway, you can just search his name on the VF website and you will see that. And having said that, I'd like to thank you for the time that you gave us today so that we are better educated in about the safety study and any other studies that are coming up. And we just also want to thank the Vasculitis Foundation. So I'm going to hopefully share screen here. Yes, we'd like to thank the Vasculitis Foundation for supporting these webinars for patient education. And Dr. David, of course, thank you. And our sponsors, Amgen, AstraZeneca, and Novartis.
Thanks very much, Kathy. And yeah, a big thank you to Vasculitis Foundation. I think it's great that the foundation has these patient education materials, and it's a rare disease, and patients are often a bit overwhelmed initially when they get their diagnosis, and to have these resources, I think is so great for patients, and it really helps them out a lot. And to be able to get this information or connect with other patients, it's really great. So thank you to Vasculitis Foundation and for the support they've given to getting my project started.
Thank you very much, Dr. David. That was a really interesting webinar. I mean, obviously we've done past webinars that talked about steroids, but I don't know about you, Kathy, but I was like, wow, I'm understanding this actually. I'm getting the concept, that I might not have gotten in some past ones. So thank you.
Yeah, the little bullet in there was when you said it's not really we're reducing the massively reducing the amount of steroids that you need right at the beginning, but the length of time that you might need it for, because so many of us have been on steroids for 3 or 4 weeks for other problems, sinus infections and things, that does not seem nearly as scary as the year at a time that I was on steroids and then having to taper off and having adrenal insufficiency and all, that stuff is scary. But this sounds wonderful, especially coming from somebody who had, I did have in my initial induction, I had plasmapheresis, and I was very bad though. I was this close to dialysis. So it's really great to hear that this study is out there, and I hope it's super successful and everything works out great.
Yeah, same here. I really do. And I think I think that obviously I am hopeful, and I think that we will be able to find a way to reduce the steroids and really patients, like you said, patients that get 2, 3 just a couple of weeks of steroids, they don't suffer as much in terms of the side effects as we see with the months of it. So I think that's really the key, is to just shorter time.
Yeah. Yeah. Well, great info. And again, thank you so much. And maybe we'll be meeting down the road in another webinar. I told Kathy you have a nice style. You present well. So
Thank you.
we
I
may
think
tag you for maybe a kidney Q&A or something down the road. So
no, absolutely. If something comes to mind, please get in touch.
all right.
I'm happy to help.
Well, thank you much. Okay, great. Well, we will talk to you later. Take care of yourselves.
All right.
Good to
Thanks
see
so
you.
much. Thanks, Kathy.
Bye-bye.
Very nice seeing you.
You too.
Yeah.
Bye.
Bye-bye.
If you see Dr. Falk, tell him we met. He'll like that.
I will see him. I don't see him again till October, I'm happy to say, but I will see him in October.
Try to play a little practical joke on him for me, or